boy, sometimes when you're told you have diabetes or any sort of illness, you feel like it's your fault. It doesn't discriminate.
Yes. Hi, my name is Kaden.
My name's Abhi.
And we are here for the Glucose Roundtable podcast. We are a group of teenagers who are involved in a nonprofit organization called the Relief Care Foundation. And our goal is to sort of support patients with diabetes worldwide through podcasts such as interviewing with professionals like yourself, and also through widespread access on social media and other platforms where we can spread our work and initiative.
So right now we have with us Miss Baker. She's an acclaimed dietitian and a nutrition. She's worked with diabetes patients extensively. So Miss Baker, would you please mind introducing yourself in a bit more depth, a bit more detail to our viewers?
Yeah, so first of all, I want to say how impressed I am with you both. I think it's incredible what you're doing, and yeah, I hope to find out where I can follow you on social media. That would be great. I'll definitely look forward to that. But thank you for inviting me. So yes, I am a registered dietitian. I'm a certified diabetes care and education specialist, a certified nutrition support clinician, and board certified in advanced diabetes management. And I've been in practice since 1983. So long time, 43 years. It never gets old. There's always stuff to learn. I'm always in school, basically. So really, that's kind of how the medical field, any kind of sciences, it's continuously evolving, continuously. There's new things to keep up with, especially technology. So, yeah, it keeps me on my toes. And, this is why I'm really happy to share. It's still a very gratifying field to be in.
Right, absolutely. Yeah. I mean, all the credentials are there, and obviously you've been in the field for a long time, almost close to 5 decades in a couple of years. So that's a really long time. It really establishes sort of your ethos as a dietitian, and especially within the specific field of diabetes, which is, as you might know, an ever-growing disease that's been affecting not only just American, but youth, adolescents all throughout the country and the world globally.
Yeah,
Yes,
yeah.
absolutely. Yeah.
It doesn't discriminate.
Yes.
All across the age span, men and women, and all races. Of course, there's different, incidents of it because of different environmental things and influences, genetics. But yeah, it affects people widely, for sure.
So to start off with the information part of our podcast, we want to talk a little bit more about you and how about your journey through this field. So your path into diabetes has a personal dimension, right, that a lot of people don't know about. So can you please walk us through what got you here and what drew you both professionally and personally to diabetes specifically?
Yeah, and I think many people in my field may share a similar story, but honestly, the first time I heard the word diabetes was when I was maybe about 7 years old, maybe younger. And my grandfather was visiting, and in those days, we had these wonderful cookies called Oreos. I think they're still around.
Yeah, they are.
But I said, Grandpa, here, have a cookie with me. And he said, I can't, I have diabetes. And I'm like, what's that? 7-year-old, what do you think about that? I still remember. And then as time went on, another very specific thing in my high school years, when I was your age, absolutely your age, my dad, and this was 1975 or 76, my dad started becoming thirsty all the time, just not doing well, lost a lot of weight. He was always a larger guy, but he lost a lot of weight. And then told me one day he had diabetes. Again, this is 75, 76. We had no glucose meters, no good medicines, no good education. And I remember then I went to college and I came back from my first year, and he just had really deteriorated. He lost a lot of weight. He looked pretty ill. I still didn't really know anything about it. And then as I got through college, got into my postgraduate work, I happened to be able to work with children with diabetes at a camp setting in 1982 for about 2 weeks. And these were little kids, kids between 5 and 18-year-old for 2 weeks. All we had was vials and syringes, no glucose meters at all. And wow, was that an experience? And then after that, worked in hospital settings for 15 years, outpatient settings, doing a lot of work all through the decades as the knowledge and the therapies and the technology for diabetes evolved. We just found out much more about it, but I still worked with people who just had so many struggles and complications. I mean, just things that I will never forget. And even to this day, even though we have great, great medicines, great technology, great, education, it's still a really big struggle. It's still just a really big stress on people. It's like getting a full-time job that you didn't ask for in terms of what people are asked to do. So it's not just about physical health and the medicines, it's also a very big mental health thing. It's just about people trying to do the best they can. And, sometimes it becomes exhausting and you just want to give up. So it's not just helping people with the information and education, it's having a lot of care and compassion and support versus stigma and judgment, which is so prevalent in so many ways. So there's a lot of dimensions to it. And you learn as you go. I'm still learning. Every new patient or client I see, I have to listen more than talk, which isn't always easy, but it's one of the most important parts of supporting
Right.
people.
And mhm.
I hope I
Oh
did a good
no,
job.
Yeah, you
absolutely,
did.
you're
That
doing
was
amazing.
amazing.
Yeah. And I think that that's a great lead in and a good narrative into how you started your career, as both of us actually have personal stories as well that relate to diabetes. Similar to yourself, my dad and my grandparents both have diabetes. So that personal
Yeah.
element, at least for me, inspired me to hone in on the specific topic of diabetes within the vast dimension of the mental health and clinical work that is basically surrounding the entirety of the globe right now. So, yeah, I like that personal touch that you gave as well.
Oh, I'm glad that landed with you because again, boy, sometimes when you're told you have diabetes or any sort of illness, you feel like it's your fault. You feel like you made it happen. That doesn't help anything. So, as I mention all the time, shame and stigma is not healthcare. Like blaming someone for it, which happens so much, but nobody asks to have
Of course.
Of
diabetes.
Right.
course, yeah.
We got to
Yeah.
remember that. Yeah.
Yeah. Okay, so now you mentioned that you mentioned that, well, like when you first started your career and when you first started exploring diabetes, like with your experience with your grandfather and father, that was over like 50 years ago, right? So when like diabetes related medicine and medicine in general wasn't nearly as advanced as it is now, and you've been working in the
Oh
field for
yeah.
over 40 years too. So like you've seen a lot of advancement. So could you please like explain how diabetes care, like regarding social stigma, medical knowledge, diet knowledge, everything was different when you first started versus now, and how it evolved in between?
I'm glad to, and I have a good visual for you too. So this is a publication that comes out every year by the American Diabetes Association. You can find it online.
Okay.
You go to americandiabetesassociation.org or ada.org. You go to Standards of Care in Diabetes 2026. I read this. I actually read it about halfway through. To me, it's valuable. I have an app for it too, so I can search things because, that's helpful. This is updated every year. When it first came out, I think 2009, I think that was the first time this was published. It was 9 pages
Mm.
long. So now it's like so much and very valuable resource. So yeah, when my grandfather, told me he had diabetes, he just had this one pill. It was an oral medication in a class of medications called the sulfonylureas. That was really the only pill that was out there. Of course, there was insulin that was discovered in 1921. Before this discovery of insulin, that's a fabulous story too. It's very interesting to look up. People who were diagnosed with diabetes had 6 months to live, basically. It was like an aggressive cancer. So before the discovery of insulin and it's being available, people, specifically with type 1, because a lot of people didn't live long enough to develop type 2 and there was no testing for it. But people who had type 1, they just didn't live long. It basically ate away your body because your body couldn't use glucose. And there's photos online that you could see. It's a fascinating story. So yeah, as time went on, insulins were developed, a few types of insulins that aren't around anymore that we used during the summer camp. That was the only option for children. It was vial and syringe injections twice a day. And then we started to have newer insulins develop that were developed to last longer, to be short acting, long acting. Instead of syringes, they developed insulin pens so you could like dial up and inject. And then the whole category of non-insulin medications started with a class of medications called the sulfonylureas, which tell your pancreas to squeeze out more insulin if it's able to do that. But then there was the discovery of other classes called the biguanides, the metformin, which is still in use and very useful. The TZDs that work on the liver and the muscle for sensitivity to insulin. Another class called the alpha glucosidase inhibitors, which work on your GI tract to slow the absorption of carbohydrates. But now we have these wonderful newer medications, which are now really high up on the algorithm in the standards of care. There's an algorithm that we use in a lot of aspects of medicine to decide what the best fit is. So we have this class of medicine. It's been around several years now, but it's a newer one called the SGLT2 inhibitors. It works on the kidneys to inhibit the reabsorption of glucose. It also helps the heart. So in this world of diabetes, it's not what we call glucose-centric anymore. The newer approach is cardiometabolic care. That's the new approach we're taking because diabetes affects the heart, the kidneys, the liver, even the brain. And so we're looking at medications and therapies that protect the heart, the kidneys, which are two main complications. The liver disease is a very big focus now as well. But even in college, when I was in college, and this was around 1981, 81, when I was in my upper division classes, one of my favorite professors always said, and you may want to write a note about this, if you don't know the answer to something on the test, write the liver. Because the liver does a zillion things. And yes, come around 40 something years later, the liver is a very big focus in diabetes related care and therapies. And there's a big focus on liver disease. And then we have now this other amazing class of medicine that's very hot on the press, but actually has been around since 2005. And I was one of the first trainers on this. It's the class of medications called the GLP-1s, the glucagon-like peptide class. I was trained in 2005 to train patients how to take it. It was more complicated. You had to mix it. You had to inject it twice a day. It was called Byetta or Bidurion. Now that's evolved over 20 years to, of course, now we have semaglutide, we have tirzepatide, otherwise known as Ozempic, and Mounjaro, very important diabetes medicines. And of course, in the past few years, they've also seen the side effects as weight loss. Now they're prescribed in higher doses for people who, need to lose weight under a doctor's care. They're safe and effective. Like any medication, it's got to be carefully prescribed and followed. But, there was a few other medications I didn't mention, but basically there are a lot of great choices, and a lot of them are used in combination and in different ways so that we can get some very personalized and individualized therapies for people alongside with the knowledge about lifestyle, nutrition, which I used to teach very differently than I do now for a number of reasons. Nutrition, the importance of physical activity and movement, especially strength training, um, sleep. Sleep is a very big metabolic influence, and we're finding that people who sleep well, that's a very big part of hormonal control and metabolic control, cholesterol control, blood pressure control. And then, as I mentioned, it wasn't really until recently that we really, really understood how important this is, the mental health part of diabetes management, how much it affects people's lives on day to day, and what kind of burden that could be. And also, diabetes changes over time, just like we need different eyeglasses as time goes on. Diabetes changes over time because of the fact that as people age, kidney function changes, all kinds of things change as you age. You see your parents and your grandparents. They were once 16 like you, and they did different things, and they thought different things, and had a different level of activity. So the aging process also changes needs as well.
Right. And you talked about.
I hope I covered
Oh,
that.
no,
Of course you did. That was
absolutely.
really informational.
Yeah.
It's really detailed. Thank you.
Yeah.
But so just to summarize for our audience, and please correct me if I'm wrong. So what you're saying is that when you started initially, apart from like the development of new medicines, diabetes was seen as like a single disease, like not like the common cold, but it's treated like the common cold. Just take this and then it should be fine. But now it's seen as a more like a holistic disease. There's more personalized, more varieties of treatments and medicines and stuff based on your specific like issue with diabetes, right? Is that right?
Yeah. In fact, when I meet with a new patient or a new client, one of the things I ask is, what's the hardest part about diabetes for you? How does this affect your life? How can we make this easier for you? I let them be in the driver's seat in terms of that, because we can have all the therapies, all the technology, the CGMs, which I've been able to wear and experience. I've worn insulin pumps. I mean, we have amazing technology and it's getting better. But, again, you don't know what kind of job people have, what their insurance covers, what their life is like. What they're worried about. So it's letting them have agency and engagement in this, and saying, yeah, this part of diabetes, yeah, it really bothers me. The numbers make me crazy. And so then we go, what about the numbers make you crazy? What does this data that we get all the time on these CGMs and the pump and or the finger sticks? What bothers you about it? And so sometimes we have to find a way to, again, do our best to decrease the diabetes distress. There's actually a survey called the Diabetes Distress Survey, Diabetes Distress Scale. I can email that to you if you want to. It just measures how much of an impact diabetes has in their life and what kind of burden it has. So we look at that, and also what are their goals of care? Like what's important to them? Do they want to, get some weight off? Do they want to maybe take medicines that doesn't have as many side effects, because any medicine has a side effect? So, it's putting the patient in the central part of it and seeing how we can decrease the burden as much as possible while making sure they're educated about, we're also wanting to make sure we're protecting your kidneys. This certain class of medicine protects your kidneys better, protecting their liver. You can't see or feel your kidneys. It's very silent, but we know kidney disease is a very big deal. And in reality, we have new medicines that protect your kidneys better than the older ones. So, yeah, it much less risk of your kidneys not working well, much less risk of going on dialysis, which scares the heck out of people. But now we have these therapies, and people are confused. They hear things from social media, the internet. They don't know who to believe anymore. I can promise you that. So, again, it's information and giving them, the education so they can decide what's important to them, and also encourage
Right.
questions.
And obviously, you've mentioned a lot of effects that can happen just from diabetes, but also you mentioned a lot of underlying causes, for example, sleep and other maybe psychological components.
Sleep is a
Yeah,
big deal.
absolutely. And as you mentioned these causes, is there something that you like to notify or offer advice to your patients about, whether it's type 1 or type 2 patients, or maybe even a generalizable advice that you offer, maybe for those who are currently having trouble with diabetes, or maybe even those who do not have it but are at risk? So anything that you can offer to
Yeah,
them for them to have the best way of life to prevent diabetes or lessen the effects of diabetes.
sure, sure. And again, what I always say, the stuff that works is not sexy.
Right.
It's not glamorous, and it's, again, it's different for everyone, but the low-hanging fruit, which I call, is very much the basics. The sleep is a big thing I talk about. It's like, we know there's so much great science out now about sleep, about getting regular sleep. There's some great evidence out about making sure you're going, you have a sleep schedule, you're going to bed on time, get this much sleep, your sleep hygiene. It's one of the biggest things because of the way that during the night, your brain detoxes yourself. It controls hormone, that controls blood pressure, blood sugar, uh, cholesterol, appetite management. I mean, it's just not glamorous, but it's a big deal. So the sleep, it's movement. So we know more than ever now that, being active, whatever people are able to do, strength training, resistance training, whatever you can fit in, really engages the muscles to be more sensitive to your own insulin. Everyone's different in what they like. I used to run. I used to do half
Wow.
marathons.
Nice.
That's not me anymore. That was my early part of my life in my college days and through my 30s. Now I walk 5 miles a day. I lift weights. My body's different, but I'm still as active as I can be. That has huge preventative effect. Um, Eating regularly, no crazy extreme diets. None of those work. They never have. But including foods in that support your health. It's nothing complicated. But also in the diabetes world, there's a lot of fear about foods, fear and anxiety about foods. And so, this whole idea that you can't eat this, you can't eat that, that's one of the things that actually causes harm. Because when people have a lot of fear, anxiety, and stress about food, it can lead to what we call eating disorders, disordered eating. I work in the eating disorder field. I have since the 80s. I've seen people die from eating disorders, and eating disorders are just about twice as common in people with diabetes because of all the very bad information they get, and misinformation and fear, that in itself is very harmful. So I work with people actually who have the dual diagnosis of diabetes and eating disorders, and that is just, it's damaging, and it's much more common than we realize. So it's regular movement, it's regular sleep, it's bringing in nourishing foods, eating enough, but also bringing in foods that bring you joy and pleasure, that are part of your culture. We don't need to be ethnocentric about food. It doesn't need to be European, white European plates. It needs to be, you know, fitting into people's backgrounds and cultures, and we can do that. So people are used to thinking, oh, well, I can't have pasta or I can't have white rice. That's not true. I make sure we get the foods in that are important to them in their culture, that they enjoy, and we can work it out. That's a really big deal. um, and again, good hydration, another big one. And it doesn't make me popular, but I have to address alcohol intake, because alcohol, it's a drug, and it can cause a lot of problems with your liver, with your heart. It doesn't support health. It actually causes a lot of sleep issues. It's a big carcinogen, and yeah, that's why no one invites me to parties. But, the fact is that it really disrupts blood sugar a lot. It's very toxic to the liver. So I'm very out front, and I say, this is how it is. You can make your decision, but you need to know how alcohol works in the body, especially if you're taking other medicines or you have other medical issues going on. So those are some of the basic things that I go over. Of course, I also want to make sure people are getting regular screenings and checkup, like their feet are checked. Your feet are very vulnerable. They're getting regular lab work, urine test. The dental part is very important. Dental disease affects blood sugar, and diabetes affects your dental health. So there's things I go through with people, very much foundational, and then we can work on the details.
I see. Okay, so you see patients at a primary care clinic week after week, right? So in your experiences, what does a typical day in diabetes management look for the people you work with? Or look for you and the people you work with, and how often does that match what people on the outside think it looks like?
Well, it can be very different in my primary care practice. Um, you know, Unfortunately, this is the way the medical system is. You know, Physicians or physician assistants or nurse practitioners, they really have 15-minute appointments with their patients. That's how they're told they have diabetes. They get their labs, they see what a common lab test called the hemoglobin A1C. That's like a 3-month average. It's a weighted average. If it's above 6.5, that's a diagnosis of diabetes. They may have also had symptoms, maybe they didn't. A lot of times, people who have diabetes have absolutely no symptoms. They come into their doctor after their checkup or their lab work, and they're told that. And they have 15 minutes to talk about, okay, I'm going to prescribe you this and that. And then they say, okay, go see Janice or go see the dietitian diabetes educator. And it's just like dropping a bomb on someone. They're sometimes really shell shocked. So they come to see me. And again, I typically have a lot more FaceTime. So I'm going through the basics. Again, it's more about having them tell me about what they know about diabetes, what they've heard. Do they have any family history? What do they know? And what are the first steps? And also, a big point is to let people know there's no perfect. A lot of times people think, it's all or nothing. Your blood sugar has to always be this. You know, just like anything, there's no perfect. And so sometimes we just need to experiment a little to see what works. I help them to understand what the numbers are if they have a CGM or they're testing their blood sugar with a finger stick. And there's a nice handout I use, and I can email it to you if you like. 40 There's 42 factors that can affect your blood sugar. 42 things can affect your blood sugar. It's not just the cookie, it's not just the banana or whatever. 42 things. It's really a nice handout. I can send it to you if you think it would be useful. And I say, hey, look at this. I mean, it's not just the food, it could be stress, it could be other medicines you're on, it could be, um, dental problems, it could be another infection. So it's just helping them see what I call the wide angle lens of things, and like, okay, this is a work in progress. We can't go from all or nothing right away. It takes some time to sort of figure things out because everyone's body is very different.
Right. And now we have sort of a fun segment prepared, not only just for the sake of our conversation, but for the potential
Okay.
listeners. It's something that we designed to be called myth or fact. So we have prepared three little
Okay.
small potential facts or myths, and then we would love to hear your input just briefly on each one, on what your stance is and what you have to say about it. So our first one that we have is a pretty common stereotype associated with diabetes, and it is eating too much sugar is what causes diabetes.
Yeah, I heard that when I was 7. And that is actually 60 years
Does that
ago.
still hold up though?
I heard it like someone said that. I can't remember who, but that's a myth. That's a myth. It just doesn't work like that. Diabetes has many reasons. It could be it's an autoimmune disease. In the case of type 1 diabetes, your body's producing antibodies to your insulin and to the cells in your pancreas, the beta cells. So no, you develop diabetes because of this autoimmune disease. Second, a lot of genetics. Some people, like myself, I have a family history of diabetes. I have a higher risk. Genetics isn't destiny, but certain ethnicities have a higher risk just because of evolution. Like what used to keep us alive in times of famine? It's called the thrifty gene. Now we're not living through famines and food shortages, but the way our bodies evolved to store fat a certain way or to metabolize things a different way, what used to keep us alive is now working against us. And that doesn't change really quickly. So, no, I could sit here today and I could eat a dozen Krispy Kreme donuts, and I'm not going to have diabetes at the end of the day. Hey, listen, I will be happy to prove it to you. So no, it doesn't work that way. Now, on another note, like if you have a pattern over time of eating a diet that's like really high in sugar, you're eating 5 donuts a day for breakfast and Slurpees and Kool-Aid and Cheetos and stuff, and you have a pattern over time of eating a diet that is very high in sugar and fats and very low in nutrients. I mean, you're developing malnutrition actually, but over time, combined with other influences like genetics, like lack of nutrients, like lack of movement, it's not guaranteed you'll develop diabetes, but you know, you're increasing your risk. So it's over time that that might be, yes, an influence. Diet does have an influence for sure. But this is a great
Right.
question.
Okay.
Okay, so our next question or our next myth or possible fact is people with diabetes cannot or should not eat carbohydrates. This is kind of similar to what you
Oh
just
yeah.
answered.
Yeah, that just isn't true because carbohydrate is a very important fuel for our brain, for our body. I mean, our muscles need carbohydrate to move. So yeah, unfortunately, at this point in time, a lot of diet fads, they just keep recycling. Like it's crazy how that is. It's the truth is carbohydrate containing foods like fruits, vegetables, whole grains, potatoes, rice, pasta. They have a lot of very important nutrients, including fibers, B vitamins, very important things. So to miss out on all that is, again, causing malnutrition. Everyone's needs are different. 16-year-old who runs track, who's still growing, who's just very active, needs different amounts of food and carbohydrates than a 70-year-old who maybe isn't quite as active, obviously, way past the growth stages. So again, it needs to be personalized. But carbohydrates are a very big category of food. Again, it's, fruits, veggies, whole grains, things like that. And it's jelly beans, cotton candy, and Kool-Aid. But we need to realize that, and I tell this to my patients a lot, jelly beans can save a life. If you have somebody who has a low blood sugar because of maybe they took too much insulin or another diabetes medicine that can cause low blood sugar, you don't give them an avocado. They could die. They need quick sources of glucose from some juice or regular soda or some jelly beans to bring their blood sugar up so their brain can work, so they don't have a cardiac arrhythmia, cardiac event. People have died from hypoglycemia. So there is a place. On the other hand, people go to birthday parties or parties, and it's really awful when they think, oh, I have diabetes. I can't have, piece of this birthday cake or this holiday food. We can make it fit in. People with diabetes can enjoy foods that help them celebrate, that are part of their culture. So that's a massive myth. And I know it's repeated a lot, but keep in mind that just because things are repeated a lot doesn't make it true.
Yeah,
Of course.
absolutely. And then the last one that we have prepared for you is diabetes only affects people who are overweight.
So really common
Oh my
stereotype that we
gosh.
keep
Well,
hearing,
Yeah.
like across society.
tell that to the little kids I worked with back in 1982 who, again, they're little kids. They developed type 1, an autoimmune form of diabetes. They were not overweight. They didn't ask for it. That there's different types of diabetes. There's several types of diabetes, actually. A lot of times it has nothing to do with weight. Yes, higher weight, obesity can increase risk factors in more vulnerable people, depending on genetics and other factors. But no, people of all ages, all body sizes can develop diabetes. I can develop diabetes even though I'm in a smaller body, but I have a family history of diabetes. So, yeah, I have a higher risk. There's a type of diabetes that can occur later in life. It's called latent autoimmune diabetes in adults. It's a slower form of type 1 diabetes. Sometimes it's called type 1.5. It's an autoimmune diabetes. We see people in smaller bodies. It's a slower form of autoimmune diabetes. It has nothing to do with weight. And it's often misdiagnosed. People with type 2 diabetes are misdiagnosed with that until the doctor orders, I have to often ask for this, orders blood tests to find out if there are autoantibodies, because things are not making sense in their clinical presentation. So, yeah, that is a big myth, sadly. And again, we need to make sure that people understand what the reality is. Yeah.
Of course, yeah, yeah. I think that's really important. Like that's the main reason we have this segment, so that people know, like people can understand like common misinformation they hear in society about diabetes and recognize that it is misinformation. So, uh, that's all we have for you today. Thank you so much for appearing on our podcast. This has been an amazing conversation, and it's an honor to start off our podcast with you. So before we end, is there anything that you're working on right now, like a resource you want our listeners to know, or an organization that you're part of, anything like that that you think would be beneficial, or you just
Oh,
want to plug?
yeah. That's a great question, honestly. And yeah, I've worked with a lot of great organizations. So over the course of time, I've done a lot of volunteer work. I still do a lot of volunteer work because, I have a great passion for this and I love what I do. But a really great resource, and it's fun too. There's an organization, it's actually based down here in San Diego. It's run by two endocrinologists, diabetes doctors, who themselves have had type 1 diabetes since they've been 15. The organization is called Taking Control of Your Diabetes, tcoyd.org. I know both of the endocrinologists. I've been volunteering with them for, close to 30 years. They put out great educational, informational podcasts, YouTube videos, events. So tcoyd.org, it's just great. And because these two endocrinologists, they have diabetes themselves. They wear pumps, they wear CGMs, they do all the stuff. They still, even though they're board certified endos that treat diabetes, they still have struggles they talk about. I think it's just one of the most interesting and fun resources in their podcast, which I love, is they always have really great guests on. The latest one is all about tech and diabetes. I think it's phenomenal. And again, it's hard to keep up with all the stuff in that world, but I think that would be a really nice organization, website, podcast. They have an Instagram to check out, and they're fun. They try to be humorous and really kind of be uplifting. So I think that's a really important
Right,
thing
and
too.
thank you so much for sharing us that information. I'm sure many people would benefit off of that.
Yeah, sure.
And just to close things up for our listeners, if anything in our conversation today with Dr. Baker resonated with you, especially around the nutritional facts or the emotional aspects of diabetes, then we really encourage you to go look up Dr. Baker's work at Taking Control of Your Diabetes. And as Dr. Baker, you might have social media or anything where people can find you and your work. Yeah.
Yeah. So I'm not, you wouldn't find me on, I've done a lot of work for them, but I'm not on TCOYD. It's Dr. Jeremy Pettis and Dr. Stephen Edelman. They're the gurus who run the whole show and do all the podcasts and all the stuff. I just love them to death, and I share their resources with my patients all the time. So I'm not on there, but I do have social media. Basically, I have a Facebook page. I know Facebook's for old people, right? But Baker Nutrition is my Facebook page. And then I'm on Instagram, it's just sort of hit and miss, but Janice Baker, RD, CDE. I am honored, but I'm not a doctor. So I have all these background things, but yeah, I don't have the doctor thing. So I'm a registered dietitian and, all the other stuff I mentioned. But, on my Facebook page, Baker Nutrition, you can join me there, throw in some questions, or my Instagram, Janice Baker, RDCDE. You can find me there too.
Alrighty.
Okay, so again, thank you so much for being on our podcast. And to everyone listening, if you found this episode valuable, please subscribe, leave us a review, please follow our Spotify account, and share it with someone in your life who could use it. And we'll see you guys next time. Thank you. Thank you, Miss Baker.
Thank you so much for your time.
You're welcome.